Medurstand. Understanding Medicine.
I'm Professor Aziz Rehman, and today we are going to continue with our discussion on adrenal diseases. And after discussing Addison disease and Cushing syndrome, we're going to talk about pheochromocytoma. Now, you know the structure of adrenal gland. Right in the center is adrenal medulla, and this secretes catecholamines, both adrenaline and noradrenaline, in response to stress situation. But sometime, and this is of course under body's autonomic control, only the right amount of catecholamine is released only at the right time. But if a tumor arises from this, which has the capacity to produce catecholamine, that can cause a lot of conditions like hypertension, palpitation, and the tumor may itself cause the problem. Now, tumors of adrenomedulla pheochromocytoma, the pathology, usually it is unilateral, but it may be bilateral in some cases because of genetic predisposition. And it is usually benign and functional, producing catecholamine, but occasionally it may be malignant. Malignant tumor may also produce catecholamine and may be non-functional also. Mostly it arises from the adrenal medulla, but occasionally catecholamine producing tumors may arise from extra-adrenal tissues like ganglions, and these ganglions are situated almost everywhere in the body, starting from neck to the pelvis. One can find a tumor in the neck or mediastinum or abdomen or pelvis. So these tumors are difficult to localize and usually sporadic, but may be part of men. Sporadic means that somebody just gets it and no family history, no history of neuroendocrine tumors, but sometimes it may be part of multiple endocrine neoplasia, which has got some genetic basis. Now, if you have a case who has this pheochromocytoma, I think it would be mandatory to screen him for men, because if that is the case, then patient may be having other tumors which might require attention. Now, pathophysiology, how is this the typical symptomology develops? Basically, it's a tumor which arises from the adrenal medulla like any other tumor, and it is functional. It produces catecholamine, which is the normal function of adrenal medulla, but the same tumor may arise from the ganglions, and that is called paraganglionoma. And you know, this secretes norepinephrine and epinephrine. Both have the same sympathomimetic action, and they cause intense alpha and beta stimulation. You know, alpha receptors are situated in all the vessels and they are vasoconstrictor. So once there is pathological or excessive amount of norepinephrine and epinephrine in the system, there would be vasoconstriction. Now this would translate into increase in blood pressure and also classical pallor, which is characteristic of the condition when patient has an attack. There will be stimulation of beta receptors, and beta receptors, they are again situated on the vessels, but they are also situated on the heart. So due to beta receptor stimulation, there is likely to be tachycardia. So peripheral vasoconstriction with tachycardia and increased cardiac output would lead to severe hypertension. Vasoconstriction and tachycardia and hypertension, palpitation, pallor, and diaphoresis. Now these four are characteristic feature of this condition when patient has attack. Pheochromocytoma patient may have episodes of attacks that the symptoms are hypertension, palpitation because of tachycardia, pallor because of skin vasoconstriction, and diaphoresis again because of catecholamine. So if somebody comes with this four features, there should be very high index of suspicion of pheochromocytoma. Clinical feature: paroxysm of headache, hypertension, palpitation, tremor, pallor, and sweating. So this actually we discussed earlier. Patient with headache, having very high blood pressure and also palpitation. When you measure their heart rate, it is high. They may be having tremor. Again, this is the factor of catecholamine. pallor because of the vasoconstriction of the skin, and sweating. So this is actually the feature which differentiates it from many other conditions. So sweating along with this symptom is very classical. And severe and intractable hypertension. Sometimes patient may not have this classical symptomatology. He or she may just have hypertension, but it is just not responding to the standard treatment. So normally whenever patient with hypertension do not respond to triple combination therapy, we do suspect resistant hypertension, and one of the causes of resistant hypertension is pheochromocytoma. A tumor in the adrenal gland will be easy to diagnose, but the tumor sitting in some ganglion may be difficult. Weight loss, a non-specific manifestation, but is also a feature of pheochromocytoma because of increased metabolism. Now, orthostatic hypertension. For students, this may be a little difficult to understand because we are mostly talking about hypertension when we are talking about pheochromocytoma. But because of vasoconstriction and diaphoresis, these people, they have contracted extracellular compartment. And whenever they are off peak, there may be vasodilatation because blood vessels go back to their original tone. And at that time, if patient stands up, there may be hypotension. So in the context of the symptomatology, without medication which can cause a postural hypertension, if somebody has this postural hypertension, that should raise the suspicion of pheochromocytoma. Differential diagnosis, the many condition, panic attacks. Now, panic attacks are very common, much more common than pheochromocytoma. But panic attacks is just anxiety, and people just believe that he's going to have a heart attack. There may be palpitation, blood pressure is usually high, there may be headache, but not of the degree which we expect in pheochromocytoma. So I think unless you are very sure about panic attacks, it is always good to have some tests to at least consider the possibility of pheochromocytoma in those patients who present with panic attacks. Medication, there are a number of drugs, especially if somebody is hypertensive. If he takes something as simple as flu medication, and antihistamines, they have vasoconstrictor effect and they can cause similar symptomatology. Then labile essential hypertension. In essential hypertension may also be labile, and it may comes in different attacks. So it may be just simple essential hypertension. And drugs, these days, unfortunately, people take recreational drugs, and some of the drugs like amphetamine, cocaine, they can also cause hypertension and this type of syndrome. Investigation, when there is suspicion of pheochromocytoma, we need to do both biochemical tests and also the imaging test. In the biochemical, I think most important is the serum metanephrine. Now, this is very special test, and we should be very particular about the laboratory, and it should be a good laboratory, and the sample should be taken by the phlebotomist himself, and it should be best taken when patient is having an episode of hypertension. But even otherwise, I believe tests can be done, but it would perhaps be best when patient is going through the episode of hypertension. Serum metanephrine is very, very useful test. Then 24-hour urinary. These are relatively traditional tests because previously serum metanephrine was not available, and we used to do 24-hour urinary VMA, metanephrine, and catecholamine. Now, what we do is we collect 24 hours urine, and how to do that? You ask the patient to void urine at a specific time, for example, at 7 o'clock. And from that onward, patient collects urine in a bottle which should be colored and opaque. So patient collects urine in that bottle. Every time patient passes urine, collects in that bottle till the same time next day. So that will make it 24 hours. So that urine should be taken to the laboratory and these things should be measured. But since this is cumbersome test and we now have serum metanephrine. So this is like, I think, almost obsolete. So we go for serum metanephrine. That is best. Then we go for imaging tests. In any endocrine tumor, in any endocrine disease, we do both hormonal assays or biochemical tests, and we also do imaging. The ultrasonography is very useful because it is non-invasive, it is cheap, it is available on the bedside of the patient, and in every medical institution we have ultrasonography. So a good machine and a good ultrasound specialist can pick up the tumor, and these tumors are typically large. So I think, and it's fairly well differentiated from the surrounding. This is the tumor, and you can see the actual size. It's given here. The image is taken from the internet, but this presentation is purely for academic purposes. It's not going to be of any monetary relevance. So I think I feel justified to use internet images. So this is the tumor arising from adrenal medulla. Then we have CT and MRI. CT and MRI both are, I think, equally good, equally sensitive. Perhaps MRI may be little more, but MRI is more expensive, not available everywhere. CT is more widely available. So if ultrasonography has not shown you the tumor, and maybe we can do CT scan with contrast. Now, contrast is also a little problematic here because traditional contrast can precipitate an attack of Pheochromocytoma, this surge episode of hypertension, palpitation. So non-ionic and modern contrast should be used. Or gadolinium is also safe. So these contrasts are used, and you can see the tumor. Now in this case, you can see if I just put on this laser, so you can see this is a big tumor. This is the kidney, right kidney, and the left kidney is like not seen here. And this big thing with some cavitation, this is a tumor. And in this image, you can also see this is a big tumor. This is a kidney, and this is a big tumor. So here you can see a big tumor. So CT scan and MRI, whichever is available, you can do it. Mostly ultrasonography and CT scan along with serum metanephrine is good enough to make a diagnosis and proceed with the treatment. But sometimes we have to do, this is called MIBG scan, and this is scintigraphy. It is available only in certain places. Now you can see the same tumor which was shown in the previous slide, almost the same size. It may be a different person, but it is almost the same left side and same size tumor. This is highlighted. The advantage of MIBG scan is that it would pick up extra-adrenal tumors also. So if there is same radioactivity shown somewhere else, that would show that there is metastasis or there is tumor somewhere else also. So that is, but mostly MIBG scan is not needed because we can make a diagnosis on ultrasound and CT. I did not discuss, but sometimes PET scan is also needed. Now, after making the diagnosis, we need to treat this patient. The treatment of choice is surgery, but with medical backup. Of course, the moment we diagnose the patient, we don't straight away go for the surgery. Patient needs to be prepared for surgery, and patient needs to be given some medication. Blood pressure has to be controlled to at least some decent level. It is a resistant hypertension. Sometimes it does not respond to medication very well, but we have to try to bring it as back to normal as possible and then have the surgery. And then after surgery, there is going to be problem of hypotension. So beware. So I think in all endocrine surgeries, it has to be backed up by a medical team. Before we undertake surgery, these patients are dehydrated, volume depleted, so we need to give them fluid. We need to encourage them to take oral fluids, but we can also give intravenous saline. So intravenous saline can be given 1 or 2 days before the surgery to make sure that these patients are well hydrated, and after the surgery they don't go into hypotension or shock. Now, treatment of choice is alpha blockers followed by beta blockers. I think I need to discuss it some little more detail. It would be very, very unwise to give beta blockers straight away, because if we give beta blockers, then all the catecholamine will have their action on unblocked alpha receptors. And if that happens, there may be actually increase in blood pressure. So first we need to block alpha receptors. Alpha receptors are much more important than beta receptors in this condition. So first we need to block alpha receptors, and unfortunately in our country there are no alpha blockers available which are used for this condition, but we can use those Cardura, doxazosin, prazosin if that is available, or and then followed by after a few days we add beta blocker. Now since we do not have proper antihypertensive alpha blockers, so I think second best would be to start with a beta blocker and alpha blocker combined activity like carvedilol, like nebivolol. So these are alpha blockers as well as beta blockers. They may be relatively safe. And direct vasodilator like hydralazine and calcium channel blocking agents may also be useful. There is the risk of severe hypertension and severe hypertension during and after surgery. Now, one of the factors which precipitate this release of catecholamine and surge of blood pressure is when we touch the tumor, even in the abdominal wall. So when surgeon is going to open or surgeon is going to operate with laparoscope, when he is going to touch the tumor, there is going to be sudden release of catecholamine. So there is a possibility of hypertension during the surgery, and so physician needs to be there with an IV infusion of drugs to control their blood pressure. And once tumor is taken out, there is a risk of hypotension because all the catecholamine is now taken out, the source of catecholamine has been taken out. Patient may still be dehydrated and there is a risk of hypotension. So all these things need to be controlled. Surgery is usually laparoscopic, but open surgery is also possible. Now, additional investigation and treatment, if tumor is sporadic, just one single tumor and benign, probably nothing else would be needed. But if tumor is malignant, then biopsy would be needed. Then after biopsy, further tests would be needed to see if it has been metastasized, and the chemotherapy and other stuff will also be needed. We also need to see if it is part of men. If patient has other features of men, there may be other neuroendocrine tumor. They may also need to be removed. The prognosis is generally good if the tumor is diagnosed well in time and removed successfully, and the prognosis may not be good if it is malignant, and if it is metastasized, or if it is extra-adrenal, and sometimes the tumor is not excisable. It is present in some place and it is not possible to remove it. Then we continue medical treatment, then the prognosis will not be good. So that concludes today's presentation on pheochromocytoma, and I thank you for viewing this video, and I look forward to see you in my next presentation. Thank you.